evening. This is going to be something like a summary session at the end of the session about all the procedures. So the purpose for which we do the surgical intervention, usually to aid in healing after the infection is controlled, or for the tectonic purpose, this is to restore the normal anatomy to prevent complications. It can be done either before perforation or after perforation, and to reduce the infection load, to aid in infection eradication, and in help in identifying the offending microorganisms. So we'll see some examples and the merits and demerits. So here the infection is obviously controlled, but the epithelium is not healing. Could be due to any reason, maybe a medication toxicity or a problem in the basement membrane as in diabetic hernia, or a neurotrophic component or a dry eye. So the usual procedures advised here are conjunctival hooding, which already Dr. Basak mentioned in some places. So it can be done, but the problem is we invite vascularization onto the cornea where it is not needed, and sometimes it can get stuck and it can lead on to unsightly vascularized scar. In case of AMG also can be used for the same purpose, because it can also provide growth factors and it can help in restoring the weakened or diseased basement membrane. But again, it can also obscure the view. So if the infection is not yet controlled well, it can lead on to problem. But if it is controlled, it can lead on to very good healing. And torsography also we have to consider in case of neurotrophic. Again, we have to keep in mind the infection should be controlled before going for this procedure. And the tectonic, that is, it can be done either before perforation or after perforation. So before perforation, in the case of desmatocele, the epithelium, here also again infection control, but the stromal destruction is so much, it's bad the desmatous membrane. So to prevent further any perforation or further endophthalmitis or other problems, we have to give us tectonic support here. So it can be done as a lamellar graft with the cornea, or it can be multi-layered amniotic membrane grafting also. The question is whether amniotic membrane can give that much tectonic support actually, because it can get absorbed after some time. But there are some reports where they have seen, analyzed this with, and they have shown that this amniotic membrane got actually integrated with the stromal structures and later got invaded with keratocytes and good scar formation also. So in case of where the stromal tissue is not available immediately, this can also be tried. And then after perforation also, again we may have to give tectonic support in some cases. If it is a macroperforation, then we can go for glue application, as Dr. Basak already mentioned. Again, we have to keep in mind the glue itself can be an irritant, so we have to apply a BCL over it. And again, if the infection is not well controlled, it can lead on to problem. And sometimes after healing, it's supposed to fall back, but after healing, it may not fall off. Then we have to remove it, and at that time again reperforation can occur. And in case of macroperforation, a large perforation, we may have to go for a graft. Here again, even in the case of 1 to 2 millimeter perforation, we can try lamellar graft if the quality of the tissue is not so good, so that later, if necessary, we can go for a penetrating graft. But here, if the perforation is very large like this, the total cornea is melted, then to avoid outer visceration or endophthalmitis and other problems, we may have to go for a limbus to limbus large grafting. The disadvantages, first it should be done as an emergency procedure. Availability of the donor tissue should be there, and of course in such a big inflamed eye, when we are doing such a big surgery, naturally we can expect complications like secondary glaucoma, hyphema, even expulsive hemorrhage, reinfection and failure are almost like common. Then to reduce the infection load, even before perforation, we can consider therapeutic graft. It can be done as a lamellar and therapeutic PK, as already mentioned. And lamellar, we can the main idea is to shorten the course, especially in chronic smoldering infections like fungal, acanthamoeba, atypical mycobacteria, where our medical treatment effectiveness is not very well established. So in these cases, we can go for lamellar in the earlier period, so that we can shorten the course. But of course, as expected, the reinfection can be more because actual microscopic invasion cannot be assessed, and also the interface bleeding and other problems may be there. But one advantage, the procedure can be either repeated or it can be repeated as a penetrating graft later. But we should, in our experience, in my own experience, very good results we can get in bacterial ulcers like Pseudomonas, where a lot of stromal melting occurred, and in case of atypical mycobacteria. But in acanthamoeba and especially fungal infections, reinfections are very, very common. And therapeutic penetrating grafts cases like this, see the surrounding seems to be well demarcated, but what you get here is only a necrotic tissue. So unless we remove this tissue, the healing is not going to start. So we have to, like in surgical expression, we have to remove this necrotic tissue and fill that area with a large graft, penetrating graft, so that it will reduce the anterior segment inflammatory complications. So it hastens the recovery also. But the cases like this, in case of wound infections where the infection is quite deep, we may have to go for a therapeutic graft full thickness even to establish our microbiological etiology, and then accordingly, like, we can proceed with the treatment, and also we can avoid the endophthalmitis. But the problem is, in such cases, often it will be decentered graft. Optically, this graft will not survive, and also mostly we will be using some poor quality graft also, tissue also. So the primary graft failure will be very common in these cases. And in sometimes, if it is very severe infection or a limbus to limbus grafting, it can lead on to limbus stem cell failure and thysis bulbae also. So that to aid in infection control, there are intrastromal and intracameral injections. Most of the reports are anecdotal, where they claim very good results. But we have to keep in mind, it's not only the infection with which we are getting all the changes, the pathology also, the tissue destruction also we have to keep in mind. So how much these injections are really useful in recovery, unless we do a randomized trial, we can't claim their superiority, but we have to wait and see. And in collagen cross-linking also, in some of the cases advised, mainly to make this is mentioned by Dr. Theosaler also in the morning, mainly to make the tissue more resistant for enzymatic digestion. So again, in infection, controlling infection, this is not going to help. Maybe in cases of Pseudomonas or in peripheral ulcerative keratitis, where the infection part is well controlled, to stop the stromal lysis, this procedure may help, and we don't have any personal experience, much experience in this. In coming to cauterization, because I just mentioned this, sometimes in the conferences, some people used to ask about this, because in olden days we used to have this thermal or chemical cautery, where many antimicrobial agents are not much available. And we have to keep in mind there will be more tissue destruction, dense scar formation, and even sometimes it hastens the perforation also. So this procedure is not at all nowadays being followed as a therapeutic measure. Thank you.